Thank you so much for having me here to talk to you today about weight management. I'm very honored that you invited me. So let's get going. I have no disclosures. And today we're going to talk about just some basics about obesity, how to screen for overweight and obesity, and then focus on some therapeutic options, including lifestyle interventions and just a bit about medication therapy as well. So we know that obesity is a chronic condition. It's characterized by excess body fat. And the reason this is concerning is because that increases the risk then for adverse metabolic, biomechanical, and psychosocial consequences. We know that in the US currently, the prevalence of overweight, which is a body mass index of 25 and above, that's about 71% right now. And in terms of obesity, it's 42%. In patients, and there are only small cross-sectional studies looking at groups of patients who have acromegaly, but in those groups, we've seen prevalence for obesity similar to general population, about 43%. There are so many different factors that can contribute to any given individual having obesity, including there's always a genetic component, often medical conditions they have, hormonal problems, medications. And because there are so many possible factors, we know that ongoing management is required to take care of weight long term. And this is just a slide that I love to show because it reminds me of my job because I'm looking for all of the possible contributors to somebody being overweight, and just also thinking about the fact that how difficult it is. You can't tell in any given individual which factor had the most weight, no pun intended, which factor was most likely to lead to that. So it's very interesting when you actually sit down and think about all the possible contributors. So I'm going to talk a little bit about some physiology, pathophysiology, about appetite and body weight regulation. It may seem a little bit complicated. By no means do you need to memorize it. I won't give a test. But I just think it's, again, just to give you a sense of how complex the hormonal system is that regulates our body weight and our appetite. So here we're going to start at what is likely a familiar area of the brain for you, right? So here's the pituitary, and just above the pituitary, that's the hypothalamus, and that's the area of interest to us today. So if you zoom in on the hypothalamus, what we see is this area up here, that's the hypothalamus. And here you can see some different organs throughout the body, but looking at the hypothalamus, in terms of appetite and body weight, there are two separate sets of nerves. And one is this set over here, POMC, or stands for pro-opiomelanocortin nerves. And when you stimulate those nerves, it causes a decrease in appetite. It decreases your food intake and increases your energy expenditure. So stimulating this side will lead to weight loss, right? The opposing neurons or nerves are these, neuropeptide Y, agouti-related protein neurons. And when these nerves are stimulated, what results is the opposite. It shuts these off and it leads to an increase in appetite, increased food intake, and a decrease in energy expenditure. So if you have increased stimulation over here, you have weight gain. If you have increased stimulation over here, you have weight loss. But besides those, what you also see is just a lot of different organs that we have in our body interact with these. So here you see insulin is the one I'm going to use, and insulin secreted after a meal to help bring your blood sugar down. And it's a signal to the body that you're in a so-called fed state. So that would then stimulate these POMC neurons to decrease your food intake because you're fed, supposedly. When you have leptin, which is, leptin is the next hormone. It's secreted from fat cells. And again, if you have more fat cells, you have more leptin. So it's, again, a sign that you're in a fed state. So that would then decrease signaling over here and decrease food intake. But something that I'll just mention is that in cases where patients do have obesity, so they have excess body fat, so you would think they have a lot of signaling over here, shutting down the appetite, the brain is not so responsive to it. So you don't actually get that full signal through. Similarly, when you have patients who have obesity that have insulin resistance, and also I'm sure you've actually probably heard about insulin resistance just in the setting of acromegaly, right? It's very common. So even though you may have a lot of insulin that normally would shut down these nerves, there's resistance here. So the signaling doesn't actually go through all the way. So looking at some of the other hormones here that interact are ones coming from our intestines. So this includes peptide YY, PYY, GLP-1, you've likely heard about in terms of some medications, and then CCK or cholecystokinin. All of these hormones, they actually shut off this side here that normally would increase appetite, they shut it down. So leading to a decreased appetite, increased energy expenditure. And that happens after you have a meal. What we do know is that in patients who do have obesity, the signaling for things like GLP-1, it's actually decreased. So here you can see in patients who have either a normal body weight or obesity, and what you see is the level of GLP-1, that hormone, it's actually decreased. So these people are not going to have that same sense of satiety or fullness after a meal. And lastly, we're going to talk about ghrelin. Ghrelin is the one hormone that stimulates appetite. So it stimulates these nerves here and increases appetite. It also is a hormone that stimulates growth hormone, which is how it got its name, because it's growth hormone releasing ligand. So this is the only hormone that actually stimulates these neurons, increases food intake. And I'll talk later about what happens to that. Some of these change after you lose weight and kind of make it a lot easier for us to regain weight. So next I'm going to talk about, and those were just things that we see in any patient, kind of the interaction of those different hormones in the brain. But when you think about with patients who have acromegaly, there may be one or two other factors that may or may not come into play. So you might see in some patients in terms of increasing the risk for weight gain, if somebody has fatigue, which a lot of times patients might see, it could be as a result of another medical condition resulting from the acromegaly, like obstructive sleep apnea. So we know that if patients have obstructive sleep apnea and it's not treated, it results in excessive sleepiness during the daytime and fatigue. Also, somebody might have arthritis and significant joint pain where it decreases the physical activity. So you're just not as able to get around as much and be as active and burn as many calories. In addition, you might see some hormonal changes, and that could be sometimes just from the tumor itself. If you have a tumor in the pituitary, you know that there are other hormones that are housed in that pituitary gland. And if the tumor is pressing on them, it can then ultimately lead to decreased levels of testosterone or estrogen or thyroid hormone. And testosterone, if your levels are low, is going to lead to decreased muscle mass and increased fat mass. Estrogen, when the levels decrease, which happens normally as women age, and what you see in terms of the changes it has on body composition is it actually allows fat to deposit in our midsection, which when you have high levels of estrogen at younger ages, that midsection is typically spared. If you have thyroid hormone being affected and it's low, of course, thyroid hormone controls our metabolic rate, so the rate at which we burn calories. So if that level is low, we're not burning as many calories, increased risk for weight gain. Also, just the treatment for acromegaly can ultimately lead to increased levels of body fat. So we know that once IGF-1 levels are decreased after therapy, whether that's with medication, surgery, radiation, there are changes in body composition. So there's a decrease in lean body mass or lean muscle mass and an increase in percent body fat. We also know, again, whether it's with radiation therapy or it's with surgery, that there can be an effect and damage to some of those cells that lead to low levels of thyroid hormone, testosterone, and estrogen. And if they're not adequately replaced, then again, you're going to see weight gain. Also, there's a specific condition which is called hypothalamic obesity. So we're talking about the hypothalamus, which is our energy and appetite center. And sometimes that area, if you have a tumor that's in the pituitary, but it's large enough that it's going up into the hypothalamus, it can actually push on those cells and affect their functioning. And that can lead to obesity. In addition, similarly as the other ones, surgery, radiation therapy can also lead to injury, damage in those hypothalamic cells. And typically, if we see it as a result of surgery, hypothalamic obesity, it's something that usually right after surgery, you may spend a day or a couple of days on steroids, kind of to decrease swelling. But after that, you may notice your appetite remains elevated. And typically patients will say that it's kind of like automatically, immediately, they notice right after surgery that their appetite, they can't be satiated. They don't have a sense of fullness anymore. So they're constantly eating meals throughout the day, snacking throughout the day. It can be pretty pronounced and lead to pretty dramatic weight gain. And why do we care? Of course, it's because there are many complications that are related to excess weight and obesity. Particularly, I just pointing out here, heart disease, arthritis, sleep apnea, because these are also ones that are very common in patients who have acromegaly. So then on top of that, having obesity is kind of like having a double whammy, right? So that's part of the reason why it's important to actually pay attention to it. It is important to address it. And when do you talk about it? It just needs to be the appropriate timing. And whether you decide or your physician hopefully will also broach this topic with you, but if they don't, you can. And it's just important to remember if something is going on, something major is going on, you're about to have surgery or you're having an urgent medical issue, is not the time to sit down and hash through your weight, issue. But also a couple other points to remember are, number one, if you or somebody that you're working with is interested in losing weight, start wherever they want to start. It's okay. Sometimes people say, well, I don't feel like thinking about what I'm eating. I just want to, get out and walk more, right? Because that can also help decrease stress and a lot of other things. So that's totally fine. If increasing activity is the first thing, that's desired, go with that. If it's making adjustments in food, fine. If it's behavior change, fine. You kind of have to start wherever it feels best. And we know, I just like to point out that very small amounts of weight loss can actually have a pronounced effect. The Look Ahead lifestyle trial, it's a lifestyle intervention where patients lost just 5 to 10% of their body weight. And what they saw was there were significant improvements in blood pressure, blood sugar, as well as cholesterol levels. Another one, the diabetes prevention program, intensive lifestyle intervention, and it showed that over the course of 4 years, there was a 60% decrease in people progressing from prediabetes to diabetes with a lifestyle intervention alone, okay? And very modest weight loss. So making adjustments, lifestyle adjustments, whether you lose a large amount of weight or not, can still be beneficial. And this is just to give you a sense of what I do when I'm seeing patients. Basically, I'm going over, I showed you that list of all the possible causes. I'm trying to figure out through my history that I get from the patient, through physical examination, as well as blood work, to get a sense of how many of these factors are contributing and which ones are items that we can treat. So how long were somebody being overweight? Right, if somebody was overweight since the age of, they remember being 3 years old and there was an issue, right? That's a very strong genetic component versus somebody who, after they had a change in where they worked or they lived. They started to drive more, maybe their leisure time, more of it was spent reading books instead of being active, something like that. That gives you a different sense of what might be contributing. Also, you want to always find out, why does somebody want to lose weight? Because it's not just about the number, right? It's a question of, does somebody want to do it to get rid of a condition, a medical condition related to their weight? Like diabetes, hypertension. Are they trying to get rid of medications that they're taking related to those conditions? Some people, they just want to be more mobile if they're having joint pains, so they're not able to be as active. That might be the case, but it's important to always think about your why, okay? Because when it comes down to it, weight management is not, I mentioned, it's a long journey. It's a chronic condition. So it's a matter of knowing why you're doing, what your motivators are, so that when you get to that time where you have a plateau, for example, for a month, even 2 months, that you can just look back and say, and look at where you've come from, what progress you've made thus far, and that can be enough to kind of keep you in the game and keep you going. Other things, are there times where somebody had rapid weight gain? That's the type of thing that makes me think about somebody who might have either problems with thyroid or Cushing's disease, which if they also might have a pituitary tumor secreting excess steroids. Also, common medications can lead to weight gain. Important to think about. I get the history in terms of any times they've tried to lose weight, what has helped, what has not. Of course, what they're currently doing with their physical activity and dietary intake. And then naturally, have they had any surgery, right, in the brain, any radiation therapy aimed at the brain, because that area of the hypothalamus could be affected. Family history, and then of course I'm going to get lab tests to be ruling out some hormone issues. Now, talking about, I mentioned weight effects of certain medications. These are really common conditions like depression, high blood pressure, seizure disorder, diabetes. And you can see that there are a lot of medications, classes of medications, that cause weight gain. And typically somebody who's giving a prescription for these medications, they're thinking about controlling that specific disease. Like, I want your diabetes under control, which is great, but it's even better if you have them think about, can you be switched to a medication that treats that condition but causes weight loss? And there are many within each of these categories. So this might be something, if you're on any of these medications, to take to your physician and say to them, hey, I'm on this med. Do you think we could switch to one that causes weight loss instead, if your issue is your weight? And in terms of screening for obesity, we all know we use the body mass index. It's weight in kilograms over height in meters squared. Now, this is a screening test, so we know that it's not perfect. It's got advantages and disadvantages. Advantages is in general populations where it's applied, it has a high correlation of percent body fat. It takes minimal time, not expensive at all, and not invasive. But in terms of limitations, and this is particularly true when it comes to patients who have active acromegaly. So it's a surrogate measure, right? It's just telling us that there's excess weight, because it measured the weight, not fat. So it's telling us it's excess weight. It doesn't say if it's due to excess fat, excess muscle, or excess bone. And particularly in patients who have active acromegaly, right, there's excess muscle tissue, excess lean muscle tissue. But also it ignores ethnic variability. So even though we have these cutoffs for BMI and who has greater risk, what we know is that certain populations, certain ethnicities, they actually develop a lot of these issues like the heart disease, diabetes at much lower BMI levels. And lastly, it ignores the distribution of body fat. So the fat we're concerned about is the fat that's near our internal organs. That's the fat that's most metabolically active. And looking at a BMI, it's just saying there's excess weight, even if it is excess fat. But if the fat is held, primarily in somebody's buttocks or their thighs, that's really not as big a concern as if it's in the midsection. So how do we get a better assessment of that? We look at something like waist circumference, because if you look at the different types of fat, the subcutaneous, right under the tissue, retroperitoneal, which is on the back by the kidneys, and then visceral fat. That's this component here, right? You see how it's right next to the heart. It's touching the heart, the liver, these vital organs. And though this is the type of fat that increases the risk for cardiovascular disease. And what we know is as waist circumference increases, that typically represents an increase in visceral fat, the one we care about. So we pair a BMI as a screener and then add on the waist circumference to give us a better idea, and looking at whether it's increased or not. And what we know is that for any class of obesity or overweight even, somebody who has obesity, class 1, and their BMI is between 30 to 34.9, if they have a normal waist circumference, their risk for having these disorders are actually still high for diabetes, et cetera. If they have an elevated waist circumference, then their risk is very high. Okay, so waist circumference can actually be quite handy. And what do we do? If somebody does have a diagnosis of being overweight or obesity, we want to start always with a high intensity lifestyle intervention. And what that means is actually, it's pretty intense. It's at least 14 visits in a 6-month period. Keep in mind, that's with any individuals that are trained in this field. So that could include somebody like myself, a weight management specialist. It could include a registered dietitian. It could include an exercise physiologist. It could include a psychotherapist. So there are a lot of different people, but that's the number of visits that has been shown to give the best results. And the goal is to lose 5 to 10% of your weight in 6 months. If you don't get to that goal, then you think about going stepwise up to different therapies. Now, I'm going to talk a little bit about lifestyle and talk about some dietary plans. I'm not going to spend a lot of time going into detail with the dietary plans. These are just because you really do need to sit down with somebody and get a sense of what style of eating would be best for you, right? In terms of weight loss itself, really the only necessity is that there's a caloric deficit, and that the person is able to adhere to it, not the type of diet. So study after study has shown any diet, whether it's the Mediterranean diet, the Atkins diet, Weight Watchers, that the patients who do well and lose weight with those diets are the ones that stuck to the diet. It's not specific to that style of eating per se, right? So therefore, it's a matter of me speaking with patients, figuring out what they like, what's available to them, what do they have time for in their schedule, right? And going with that type of dietary style and thinking about the fact that it's something you're going to do for life, right? This isn't just for a few months to lose some weight. This is how are you going to eat for the rest of your life? And, you know, sometimes choosing something tied to a medical condition might make it more motivating. So using something like the DASH diet that it's been shown, eating in that dietary style, it can actually decrease blood pressure. So that because it's not just that it has a decrease in sodium, which you would expect, I'm sure, but also it has an increase in foods that are high in potassium and magnesium, which helps to decrease blood pressure significantly. Mediterranean diet, if you're thinking about have high risk for cardiovascular disease, low glycemic index style, which is basically focusing on whole grain carbohydrates for people who might have pre-diabetes, diabetes, or even just insulin resistance. Okay. Calorie counting I put on here because, you know, but I typically don't do it in terms of recommending it. If somebody really holds my feet to the fire, then I will. But I just, again, the goal is to adopt a dietary style that you're going to have for life. Is somebody going to count calories for life? Right? I kind of think not. So for me, it's not in terms of something that's sustainable. Calorie counting is not the case. Meal replacements, sometimes patients might use for a meal. if they're always in a rush, they're running out, taking the kids to work in the morning, they don't have time to have a meal. So having a protein shake, that might be a good option, right? And it can help cut calories. There are meal delivery services, and there's different types. So some, they send you everything, you cook it at home. So if you need to have time available to do that, right? Versus prepared meals that, and they also customize those in terms of, it could be a diabetes friendly meals, pescatarian, paleo, etc. There's a wide variety. Another simple thing to do if you're just trying to start out like feeling overwhelmed, just try to get rid of calories that are not from actual food. So whether that's from juice, like eat the whole fruit instead, or getting rid of soda, maybe trying to swap out for seltzer water, flavored waters, and decreasing calories from alcohol as well. The healthy eating plate is another simple eating style to start with, where you simply divide your plate into quarters, and really half the plate is going to have whole grain carbohydrates. So whether that's brown rice or quinoa, sweet potato, and that other half there will be proteins, preferably lean proteins, so those that don't have extremely high fat. And then the other half is going to be fruits and vegetables. And that's something that anybody could do, because it doesn't matter what type of food you're eating. Meaning if there's a cultural plate, right? Whether you have Mediterranean food, or I have some patients who are Dominican and they like a certain style of food. It doesn't matter what type of food if you just divide it up by those proportions. And of course, it's always beneficial to work with a dietitian, nutritionist can be helpful. And in terms of, this is just one more meal pattern that I recommend for patients. So what's been studied is having carbohydrates last in the meal. And again, this is something where sometimes people don't have control over the actual food that they receive. I have some patients who get food from a food pantry, right? Or a lot of times certain things that are less expensive, like whole grain bread is much more expensive than getting plain white bread. Or you may be eating it over at somebody's home, so you don't have control over what's served. If that's the case, and particularly somebody who's concerned about their blood sugar or even insulin levels, what has been found that if you take patients and you give eat the carbohydrates, the breads first, versus eating carbohydrates last, versus eating them kind of all together as a sandwich approach, what was shown was that patients who ate carbohydrates last, here you can see their glucose, their blood sugar, you can see that it didn't even go up half as much if they ate the carbohydrates last. Also, their insulin, definitely significantly lower. So again, for patients who have, whether it's prediabetes, insulin resistance, this could be a beneficial pattern. And also, I'll bring you back to that hormone I mentioned before, the GLP-1. That's the hormone that I showed that it turns off those nerves that increase appetite. So it can help decrease appetite, make you feel more full. You could see that the carbohydrate last, that blue line, at all points, it was hot, that hormone went up higher. So it increased the sense of satiety even, just something by the food order, right? Very simple to do. So now talking about physical activity, and these are the physical activity guidelines, which they're not so informative. They just say move more, sit less, some activities better than none, right? And they let us know the goal is 150 to 300 minutes of moderate intensity, or half that amount if it's vigorous. And you do more activity, you get more benefit, and kind of muscle strengthening is useful as well. And the thing is, I think the goal is just to get people to move more, obviously. It's important to, again, sit down and talk with your provider, whether it's the nutritionist creating the lifestyle plan, just to think about what types of activity am I able to do? Do I have time to do, right? So looking at, these are just examples of moderate intensity activities, and versus things that are considered vigorous activity. And it's great if you have time to block off a chunk of time and do these discrete activities. But what I find more often is that patients only have very small bouts of time. So we work on how do we fit in a little bit of activity during a short period of time. So that might be something like start off your lunch break at work. The first 10 minutes, 15 minutes, go for a walk around the office, right? Getting off one bus stop early. A lot of parents, they spend the weekends, they take their kids to games and they sit on the sidelines on the benches watching the kids. And I'm like, that's the perfect opportunity for you to get up and get some activity. You can walk around the perimeter of the field or of the court, right? So it's about fitting it in, but it's always got to be specific to you. And then looking at something like behavioral interventions, and these are just other things that actually help reinforce dietary and physical activity changes, and they complement them. So things like decreasing stress, mindful eating, right? So sitting at a table without the TV on, and being present. It leads to us eating at a slower pace. Also, things like setting up the environment at the home, meal planning, food prepping, also sleep. So just FYI, some of those hormones that affect appetite, if you have, just like with sleep apnea, I mentioned that can have an effect on weight. So can just poor sleep. If you don't get adequate sleep, it's a stressor to your body. So it increases the cortisol, the steroid hormone that increases hunger, okay? And it increases insulin levels and ghrelin as well. So it's going to make you feel hungrier throughout the day if you're not getting good sleep. And self-monitoring, there are many methods, including using a journal. There are activity trackers as well. And they can be helpful depending on the person. I think they're helpful because it can just make us aware of our different habits, or if there's a trigger that leads to us, say, there's a change in our dietary intake for a while. You can always go back and say, well, what happened that triggered that? Also, it can be useful to show progress in the show, like how far you've come. I think it's important, just one note on fitness trackers that everybody wears. Everybody hears, oh, you need 10,000 steps a day. You need 10, right? That's the goal. Well, if you're starting out at 2,000 steps a day, you don't make your goal 10,000, right? You look at the week, and this is just a sample of a patient's week. And yes, even though this person got 11,000 one day, if you set a goal of 10,000, so 6 other days in the week, they're going to be completely and utterly discouraged, right? I mean, you want to set reasonable goals. So you set it a few thousand steps above what their lowest days are. So this is kind of the goal that I would set for this person. Now, looking at more monitoring, how can you and if you're following with a provider for this, monitor it, whether it could be body weight and or waist circumference, but don't put too much emphasis on any number, because there are a lot of factors that can cause fluctuations in body weight from day to day, right? So just if you eat a meal that has a lot of salt in it, right? You have soup the night before you check your weight, you're going to retain water. So you don't want to get all bent out of shape about that, okay? Another way is just to, be mindful of how your clothes fit, especially around the waist, because that's the area we're worried about in terms of cardiovascular risk. So other ways for monitoring, of course, are to check lab tests, right? Whether it's to have your cholesterol checked, the hemoglobin A1C, a 3-month blood sugar test, and you can see if there's progress there. Also, just looking at mobility. Are you able to walk for a longer distance now? Or you walk around more without using a cane that previously maybe was needed all the time, right? So there are a lot of, depending on what your goals are, there are a lot of different ways to monitor whether or not you're progressing. Also thinking about joint pain, if you have a lot of arthritis pain. And just keep in mind, it can be useful with weight loss, because of our hips and knees being lower. If you lose, for every 10 pounds you lose on your body, it actually translates times 3 in terms of the amount of weight lifted off your joints in the bottom. So if you lose 10 pounds, it feels to your knees like 30 pounds was lifted off of your knees. So these are all different things for us to think about. So now when we think about with weight loss, and I'm sure you know many people, if not yourself, who've tried to lose weight in the past, and they may, even if they lose some, they regain it, They can't keep it off. Why is that? Some things are pretty obvious. We know our environment, right? It's an obesogenic environment. Look at portion sizes, right? Today, portion sizes versus 20 years ago. Everything is supersized, right? Also, the setup of even our offices, right? You have to, I work in the hospital, and it's like the stairwells are all the way at the end of the hall, right? You really have to go look for them instead of them being centrally located. And that's the case in most offices. Also, we know that some of that, the wiring, I showed you some of those nerve pathways, hormonal pathways, some of those that are related to appetite, they overlap. There's cross wiring with some of the reward circuitry. So if you eat something that is high in fat or highly processed, a lot of sugar, it can actually stimulate something like dopamine, which is one of those chemicals that makes us feel good. And if it made us feel good, you'd probably want to repeat that, right? And in addition, one of the biggest reasons is because our bodies are set up in a way to maintain, to hold on to our body fat and to always bring us back to that weight. So, and we call those counterregulatory adaptations, right? So there are things that happen once you lose weight. If you lose 10% of your body weight, what we know is the amount of calories you burn every day decreases by 15 to 20%. So you're burning that much less calories. So obviously, even if you continued at that same, in terms of calorie intake, but you're burning less calories now, your weight is going to creep back up. Also, another thing that occurs in our body has to do with hormone levels. So we know that in patients who lose weight, once again, once you lose, it could even be just 7%, but once you lose for sure 10%, 11%, that hormone ghrelin that stimulates our appetite, that hormone, it actually increases. And it's increased around the clock, okay, once you've lost weight. So you will feel hungrier. And even though, yes, it's possible to feel hungry and not respond to it, over a lifetime, that's pretty difficult, right? Also, hormones like leptin, peptide YY that we talked about before, leptin, the levels, it's a signal of, it's supposed to decrease appetite. The levels decrease after you lose weight. So it gets rid of that suppression. Also, peptide YY, we see levels in patients who are overweight that those levels are decreased as well. So there's a lot of, if you don't get the idea by now, a lot of hormonal adjustments going on that actually really make it difficult to lose weight and to keep it off. One other I do just want to add, because I mentioned ghrelin, and it's how it can be increased once you lose weight. And by the way, that does not ever reset. It's always elevated after you lose weight. So you always have a sense of increased hunger. What we do know is one way in terms of dietary adjustment that could be helpful is if this is a study that looked at ghrelin levels over time after eating a meal. And what it found was after patients, if they were just given all carbohydrates, the ghrelin level went down pretty significantly, but then it comes back up and it overshoots the baseline, right? So you would expect to even have increased hunger after eating just pure carbohydrates versus having fat, lipid, where it comes down, but not quite as much, versus protein, where protein, it comes down quite nicely and it stays suppressed for a much longer time. So it suggests, and this is one of the possible mechanisms where people who eat high protein, low carbohydrate diets, they report a greater sense of satiety, and that might be why, right? But if somebody has, actually tried lifestyle interventions, which is always the first thing you do, and either not lost enough weight or they've lost weight but not been able to keep it off, then you would go to the next thing, part of the therapeutic chain. And that's the end of our talk, where I'm going to talk a little bit about some of these medication therapies. And again, no medication works for every person. Just as I'm sure there are medication therapies for acromegaly, and one might work for somebody that and it didn't work for you. It's similar with meds for weight. But I'll go through a couple of these. So just to let you know, noradrenergic agents, these are the ones, they've been around since the 1950s, 1959, I think it is. Okay. They are but they're FDA approved for 3 months, because back then everybody thought, take it for 3 months, you lose the weight, and and you go on your merry own life. Nobody knew that it was a chronic disease. So, and it's often used off label for longer periods of time because we expect weight regain if you stop it. And these are actually the most frequently prescribed medications for weight in the world. And that's because they have generic formulations, right? And they work they increase norepinephrine, they increase your metabolic rate, and they increase dopamine. I was talking about that hormone that makes you feel good, but it can also decrease your appetite. And typically, in terms of the efficacy, about 4% weight loss over 6 months, greater than placebo group. And basically, we don't use it in patients who have uncontrolled hypertension because it can increase blood pressure. And most common side effects: dry mouth, insomnia, headache, and they're listed as Schedule 4, so that's the same category as something like Ativan. And these are just some of the names that you might see it under. Next, I'm going to talk about orlistat. Orlistat is uncommonly used, and you'll understand why in a minute. Basically, after we eat a meal that has fat in it, triglycerides, right? So like this is a triglyceride, that's a type of fat. It gets broken down by these enzymes, and that makes it small enough to absorb into our intestines. Well, orlistat, what it does is it blocks those binding sites. So the triglyceride, it stays as a big cell and it can't be absorbed, and about a third of it goes out into our stool. Okay. And here you can see, I won't spend time going through this figure, but on average, the mean weight loss is at 1 year about 5%. And about like over 10% of patients lost, and when you look at patients who lost at least 10% of their body weight over here, you can see that, that's supposed to be 40% of them. And basically if you think about, I told you how it works, that's kind of why it's not so commonly used, right? It's blocking a third of the fat in your food, and that's going to come out in your stool. So you can have oily stool. So that kind of makes it a little, yeah. But all that to say, it's also, you could buy it over the counter. And it's not very expensive, or prescription, and it can be helpful in some patients, but you do not use it in patients who have high fat diet because the results are predictable. It's supposed to be used in patients who have low fat diets. Next, we have a medication called phentermine topiramate. Now, I already told you about phentermine and how that one works, but it's been combined with topiramate, which is actually, it's a medication that if you prescribe it on its own, it actually is for patients who have seizure disorder or who have migraine headaches. And putting those two together at pretty low doses can have some significant benefits in terms of weight. So this is just a figure showing you kind of the dosing. It's a capsule. You start at a low dose to get your body used to it for 2 weeks, and then you increase. And after 12 weeks, you check the weight. If you didn't lose enough, you can increase the dose or stop it. And basically looking at how effective it is at a year, about 8.6% weight loss. And some of in terms of side effects, again, with the phentermine, you don't use it in patients who have uncontrolled blood pressure because it can increase your blood pressure or heart rate. Typically, dry mouth is the biggest deal. It cannot be used in women of childbearing age, unless they're on a highly effective type of contraception like IUD or have had tubal ligation. And that the reason for that is because topiramate, that medication that's also for migraines, seizures, if somebody were to get pregnant, it increases the risk for cleft palate in that fetus. And here's another medication that's used called naltrexone, bupropion. The trade name is Contrave. It's a combo of 2 meds that have been around for a long time. One is bupropion, which it's FDA approved under the name Wellbutrin for depression. And also it's FDA approved under the name Zyban to help people quit smoking. So that it's been around for a while. But what we know in terms of its effect on weight is it actually activates. So looking at these nerves, that POMC nerve, that when it was activated, stimulated, it led to decreased appetite. bupropion, this hormone, sorry, not hormone, but this medication, it actually stimulates those nerves and it leads to a decrease in appetite. And the reason why they added the naltrexone portion, naltrexone is used for on its own for people who have either alcohol abuse, opioid abuse. But what we know is typically with those nerves, once you have those nerves activated, they inhibit themselves, okay? And say like, that's enough, we've put out enough of the hormone. But they inhibit themselves through this receptor here, which is an opioid receptor. And naltrexone can block opioid receptors. So blocking the inhibition, you have further secretion of the hormone that decreases appetite. And here you can see, this is just talking about some of the common side effects: nausea, constipation. At 1 year, 8% weight loss is the average with the medication. And lastly, or next to last, I'm going to talk about GLP-1 receptor agonists. I'm sure you've all heard about them. They were initially, the chemical substance was isolated initially from the saliva of Gila monster lizards. That's why I have that there. But we have this hormone ourselves, right? And basically with the hormone, after a meal, I showed you, right? It increases our sense of satiety, decreases our appetite, and it slows down gastric emptying as well. So food moves more slowly through your digestive tract. So if it's a longer period before it's empty, that's a longer time before you're hungry again, okay? And whoops. Oh, sorry, that's the slide I want you to show. So just showing you, this is the GLP-1. If you remember back on over here, it blocks those neurons, those nerves that increase appetite. And looking at liraglutide specifically, I'll just mention the average weight loss of 8% at 1 year. So again, with some of the other ones I mentioned, 5%, 6%, this is 8% now. Okay, most common side effects: nausea, vomiting, not so common vomiting, but diarrhea, constipation, or acid reflux. And it's an injection. And this one, liraglutide, is actually also FDA approved for type 2 diabetes in a lower dose under the name Victoza, a higher dose for weight management, 3 milligrams. But this is a once-a-day injection. And this has been FDA approved since, I think, 2012. And there hasn't been that much uptake. I think a lot of people did not want to do a daily injection. Q semaglutide, which is FDA approved at lower doses for type 2 diabetes under Ozempic name, and then higher dose under the name Wegovy for weight management. And you get a sense also, if you saw, I pointed out the average weight. Here you see the average weight with semaglutide, Wegovy, 14.5% at 1 year. That's really significant. Over 50% lost at least 15%, 1/3 lost 20%. So that's why there's been so much talk about it. And you may have heard within the past month that it's also been shown that in patients who are overweight with heart disease, this medication actually decreased their risk for future death from heart disease. So that's also a big deal, right? For patients who have heart disease as well. And same side effects: nausea, diarrhea, constipation. And this is a once-a-day shot. And this slide just shows you kind of the dosing, which again, I did provide the slide, so you'll be able to, if you ever want to reference these, you'll have them in your possession. And the last one that I'm going to mention, tirzepatide, this is the newest kid on the block. It was just FDA approved in November of 2023, just kind of getting into pharmacies now. And it has the GLP-1 receptor agonist, right, that we saw in Wegovy. But in addition, another hormone that we secrete that affects those neurons, those same nerves that affect your appetite. So putting them together seems to have even more benefits in terms of decreasing our intake, our appetite, making us feel more full. And what we found, again, this is again a once a week injection, similar to Wegovy, but even more impressive in terms of weight. Now we're at 20%. Is the average weight loss. So again, when you hear people are making such a fuss, it's because to finally be able to see medications that are giving this much weight loss is what's so the big deal. And again, once a week injection that just kind of has titration. Just last note, any of these medications, I showed you all that nerve circuitry, right? And if it's going to stimulate nerves or shut off nerves and ultimately lead to whether it's a decrease in appetite, increased sense of fullness, or increased energy expenditure, if you remove that medication, it's no longer going to stimulate or block those nerves, right? And you should expect that you would regain the weight. So understand that if you use a medication and it's helpful, stopping it, you would expect to regain the weight. So using these medications, it's not something, again, this isn't something you do to lose 5 pounds to get into a dress, right? This is something that you're dealing with serious medical conditions, and it's a chronic, obesity is a chronic condition, so it needs to be treated long-term. And this is lastly just some talking about, I mentioned already the different people on our team, and I'll leave the summary for you to view. The only thing I want to mention to you is, and I'm sure actually the fact that you're at this conference tells me you already know this, but I'm going to stress it. A lot of physicians are not competent. We did not learn, I did not learn how to deal with weight, how to treat weight when I was in medical school or my residency training. I took that on my own to get more information. If you ask your doctor and they're unable to help you, you have to be persistent, be your own advocate, and get a referral. You can get a referral to a weight specialist. And this just lists the abom.org, where they have actually a find a provider tab on there that could be helpful to you as well. And I just want to give shout out to my coworkers here at Columbia at the Metabolic and Weight Control Center. And thank you so much for having me.
Thank you, Dr. Reid. Can you hear me?
I can.
Great. We have 5 minutes for questions.
Fabulous.
And I see a hand.
Hi, thank you for that. Incredibly detailed.
I hope it was
I think
helpful.
you missed one. I think you missed one key thing though, and that's water. I think water in the diet is something that we are grossly underhydrated, and if we're not drinking 2, 3, 4 liters of water a day, we're never going to feel full. And I think sometimes we confuse hungry for thirsty.
You are absolutely, thank you so much for your comment. You are absolutely correct. Any patient of mine knows that I am always asking about their hydration. I just didn't put it in here, but I should make a point of doing that, because actually, just like I was talking about some of the wiring being crossed, just as you talked about, the signaling for thirst can sometimes be misinterpreted as hunger. So you're absolutely right. Hydration is critical. Thank you.
So, hey, that was fantastic, by the way.
Thank you.
We're hearing a lot more about ghrelin and how that has been linked to weight gain, and especially since it's a hormone with the acromegaly patients that our ghrelin is way off. So, is there like what is the best way to control that ghrelin so that it's not taking over our lives?
So the thing is, in terms of patients with acromegaly, it's a weird, we don't know very well in terms of how to utilize that information. Part of that is because when you look at studies, it's not always consistent, particularly after treatment, whether or not somebody's levels high, low, right? It's not consistent enough to be able to give kind of a recommendation. And what I'll say is, even in patients without acromegaly, right, who, like I mentioned, if you lose weight, your ghrelin levels are elevated. And there's no, other than using medications that kind of block some of that signaling for hunger, for appetite, doing something like I mentioned, the making sure that you prioritize protein in your meals can help keep the ghrelin suppressed for a longer period of time after a meal.
Hi, Dr. Reid. This is Jonathan Kahan. I just wanted to say thank you for speaking. This was amazing. I just wanted to make one comment and then a question. The comment is everything that Dr. Reid says is 100% correct. I was at the Acromegaly conference 2 years ago. I weighed 330 pounds and I've taken off over 100 pounds thanks to Dr. Reid. She's amazing. And way too modest. My question is for everybody else here, I've been talking you up a bit. Do you see patients from out of state?
So I see patients, I have licenses to see patients in New Jersey, of New York, of course, New Jersey, Connecticut, and Florida.
More to come?
And thank you so much for your kind words.
You're the best, Dr. Reid.
Thank you.
Any other questions before we end this session? Okay. Dr. Reid, thank you very, very much for your presentation.
Oh, thank you. Thank you so much for having me. I really appreciate it. Thank you.
Thank you.
Bye-bye.